time out of your schedule to join us, and we look forward to engaging today's subject matter. And I'm going to pull up the slides to talk a little bit more about today's title, and then also to have the opportunity to hear a little bit more about some of the things happening within Transforming Chaplaincy. Yes, welcome officially to the Congregational Care Network, Effects of a Healthcare Congregational Partnership on Loneliness and Healthcare Utilization. In addition to today's webinar, we'd love to have you come back for some webinars that we have coming down the pike. We're very excited for this group of folks to join us on Monday, October 6th, to talk about fatalism and self-efficacy. That's Dr. Leonard Aghetti, Dr. Rebecca Walker. I'm kind of going clockwise here. Dr. Kelsey White in the bottom right, and then Dr. Gila Raja'i. The bottom two will be our respondents for this event. We hope you can join us and get a few more events with QR codes in case you are able to be a part of those events. And then we have another webinar in case you're keeping track. It's Spiritual Care Pastoral Care Week, and we're happy to highlight one of our research convener people. This is Angelika Zolfrank on the left. She's a CP educator, and we'll be talking about mental health clinical pastoral education, and she'll be joined by a colleague of hers, a psychiatrist, Dr. Brandon Unruh, and they'll be a part of that. So we hope you can join us and celebrate that Spiritual Care Week about a month from now. Not webinars, but we also, in Transforming Chaplaincy, will offer short courses that you can join. And if you would like to, please consider, I threw in a little pumpkin spice coloring there for the fall for the next short course. But hear my voice. Dr. Kate Peterman, formerly at the Mayo Clinic in Rochester, many papers on the evidence-based life review intervention that she has been a part of with colleagues, and is going to be teaching that, and hopefully an opportunity for you to learn. So in case you want to advance spiritual care through research in that space, please consider joining us for that. More information through that QR code. And then we're pretty excited that the in-person Healthcare Chaplaincy State of the Science event that we hosted back in June will be a online version in late October. So in case you can be a part of that, you can get that information from this QR code or steer to our friends that will be co-sponsoring that event with Association of Professional Chaplains. So without further ado, it is my distinct pleasure to present to you our speakers and our respondent for today. So Dr. Jay Foster, Vice President of Spiritual Care with IU Health, has been in that role since 2018, but he wasn't sitting down before he took that job. He was formerly also the Director of Chaplaincy at Wake Forest Baptist Health previously, which is why I think, Jay, in a previous meeting, I heard you talking about North Carolina. And so Carolina will be on my mind with James Taylor. I love that you have these hobbies of hiking, cooking, biking, and I'm not putting married to Alice in the hobbies, but just noting that you're married to Alice there as well. So great to have you here, Jay. Thanks so much, and look forward to hearing about your important work that you did with Dr. Alexia Torkey. Dr. Torkey is Professor of Medicine and Director of the Evans Center at IU Health as well. Dr. Torkey is also the Section Chief of Palliative Medicine at Indiana University. And she conducts research and education on religion and spirituality in healthcare. Her research focuses on patient and family experiences with serious illness, including surrogate decision-making for adults with cognitive impairment and dementia. If she looks familiar, Dr. Torkey Lexi has kindly been with us before on Transforming Chaplaincy webinars. Welcome back, Lexi. So glad to have you here with us again. Dr. Ellen Eidler, it's so good to have you with us. As I mentioned in the beginning when we were in the green room, it's so nice to see you a few years later after hearing you talk when I was getting my master's in public health. She is the Samuel Candler Dobbs Professor of Sociology down in Atlanta at Emory University, and her work emphasizes that it's important to think of the impact on religion on health at both the individual and the organizational level, and to consider how partnerships of faith communities with other non-governmental organizations can be facilitated for the improvement of public health. Sounds like you're exactly the right person for today as the respondent. She was also the editor and a contributing author to Religion as a Social Determinant of Public Health with Oxford Publishing. Just in case, friends, holiday season's coming up and you need another text to throw under your holiday accoutrements, please consider that text as well. So friends, without further ado, I'm going to turn it over to you, Jay. Thanks so much for being with us for this webinar. And if you need to use or want to submit a question, please use the question and answer function for that. That will keep it queued up for you to have it stay at the top. You can also drop it in the chat, but there's a risk and a danger that it'll just keep floating downward in that. So thanks so much. Take it away, Jay.
Thank you, Paul. And I'm really excited to be with everyone today here for Transforming Chaplaincy. I am, however, afraid of folks seeing my slides correctly. Oh, Ellen says yes. That's great. Well, I'll push right through then. Let me just start by saying, again, that it's an honor to share our story with you today. Ours is kind of a modest story because it's kind of a simple idea. Can actually listening to folk and companioning them in their journey be a help to their health. You know, we tell stories to make sense of our lives. Growing up, we are told stories that give shape and color to our formative years, stories that ground us in home and place. And, you know, those sacred stories that we hear at temple or mosque or church or synagogue that have been told and retold for millennia, maybe those stories have something special to tell us about where we're come from, where we're going, about life and death, about redemption and hope. So here's the question. What happens if we tell our story and no one cares or no one's there to listen? What happens when illness or trauma hits and or when our relationships become fractured at home or neighborhood? And there's not one close to us who really cares to hear our story. Dr. Vivek Murthy, former Surgeon General, sounded the alarm that loneliness and social isolation is in fact a public health emergency. The data supports what I think common sense would say. Social isolation, loneliness is bad for you. Here, what I'd like to do for today is just go over a little bit of how our story came about. Talk a little bit about social isolation and loneliness as an epidemic, and then go into the structure of our program, the companionship training we use, and close up my comments with, you know, what are some of the risks and challenges with this model, and what are we doing to try to mitigate that? And then I'll be really excited to introduce Lexi to talk about the research end of this. I'll say it once or twice or three more times. I am not a researcher, and to have someone of Lexi's caliber guide this project for us and invest in this way is such an enormous gift. So I'm excited about sharing that part of the information with you. And then look forward to response from Dr. Idler, from Ellen, and further conversation together. So that's the outline of today. So how did I get here? Well, about 8-9 years ago, I was invited to IU Health because the health system has a really major investment in community health, at the time major and growing. And members of leadership here were particularly interested, well, what could the role of spiritual care be to address that? So I had some experience at this in North Carolina, which is how I kind of got to the table. But when I arrived here in North Carolina, we really focused on whatever the social impediment to health may be, what's a congregation that we could match that concern with? Well, here I was challenged, why don't you choose one social impediment of health to focus on and do that as a project? Well, it's a very well-known saying by the late Presbyterian author and minister, Frederick Buechner, how will I know what my vocation is in the world? And well, I'll know that when my gifts match the world's great needs. I think his exact quotes is where we find our vocation in the place where our deep gladness meets the world's deep needs. Well, CCM began 5 years ago with that simple idea in mind. If chaplains have a gift, it is to accompany folks in times of great distress. And if congregations have a deep gladness, that includes providing thoughtful and responsive care to what we in North Carolina might call the sick and the shut-in. Well, and it turns out that right now our world's deep need, I think, is for connection and purpose for all of us, really, but especially for those who become lonely and isolated and for whom that isolation or loneliness becomes embedded and even kind of a habit. So I'll say this, I'll come back to this point again and again, but folks need stories to make sense of their lives and need people to hear those stories. Well, physicians know this. The healthcare team knows that each person needs and deserves someone to really listen to them, especially during times of illness or crisis. But you know what? That's a really time-intensive need, and not every provider has that time. So that led to this simple idea. Could we partner with congregations in the neighborhood of patients who have this particular need and partner with those folk who have the time to invest, the wisdom, the experience, the knowledge of their neighborhoods to invest in their peers? As I said, I'm a healthcare chaplain and ACP educator for the last 30 years and was happily doing that work at Wake Forest Baptist Health, intensely focused on the person right in front of me, the patient, their loved one, the team member. And I must say, I love that deeply granular work of attending to persons in their spiritual journey. But about 15 years ago, a new vice president showed up at Wake Forest, who had some success with what's called the Memphis model at Laban Hoover Methodist in Memphis, a guy by the name of Gary Gunderson. Gary's a Methodist minister and public health scientist and an author, and a bit of an iconoclast, if you know Gary. But Gary and a wonderful guy named Bobby Baker were architects of the Memphis model. And I know I owe a lot to Gary, but one thing that he said always sticks out to me, which is, people don't come to the hospital to get well, Jay. They come to the hospital for treatment. They go home to get well. And if they don't have what they need at home, food, transportation, education, financial support, emotional and spiritual support, well, chances are they won't do so well. Chances are they'll end right back up in the hospital. Gary and colleagues have written broadly in the field. This book, Leading Causes of Life, I mentioned here. The title's a little bit tongue-in-cheek. It's sort of a rejoinder to the notion of public health of leading causes of death. Gary was sort of saying, rather than attend so minutely to indicators of mortality, why not focus on those things that promote health? Rather than say that the social communities, the zip codes in which we live, determine our health, maybe we do well to recognize that in those same communities come deep, powerful wells of health and wholeness. And that may be especially true in the faith community, where folk forever have been turning for guidance and for support and for direction about all manners of things related to their wellness. What I hope for those persons engaged in the Congregational Care Network is that by connecting with an individual, that maybe they would begin to reclaim a sense of coherence. And that as they reclaim that sense that I am more than my illness, maybe they in fact also reclaim a sense of agency. I have something to contribute. And in fact, I have something to share, something generative. In fact, I have hope. Just to define our terms real quick, this is taken from Murty's book on social isolation and loneliness. I'll not read it to you, but to say it in layperson's terms, you can experience a deep and pervading sense of loneliness in a veritable crowd of people. On the other hand, you can be isolated from social relationships and activities and be perfectly happy with that. Be kind of a grumpy Gus. And of course, one can feel both isolated and lonely. But the interesting thing is, as I understand it, social isolation, loneliness, either of those experiences can have a pretty negative impact on health outcomes. This idea about finding coherence in life, this way of thinking that Congregational Care Network might be able to help folk find that way, is also helped by narrative approaches to spiritual care, which in turn are informed by narrative approaches to ethics and to illness more broadly. In particular, the work of Dr. Arthur Frank, a sociologist some years ago now, he wrote The Wounded Storyteller after a life-transforming experience with his own cancer journey. He makes the point, as I've said a couple times, that we tell stories to and about ourselves to make sense of our lives, to find purpose. Well, this is especially true when we become ill. And when this happens, I think we all want the story where things turned out well. I get sick, I go to the doctor gives me a pill, I go home. But what happens when that's not the case? When illness is chronic or perhaps life-threatening? Well, we become pretty disoriented. What we have leaned on and counted on doesn't make sense. I think that disorientation shows up in myriad ways, but I like Dr. Frank's term of chaos. It becomes a chaotic time. But Frank goes on to say that it's possible, not guaranteed, but it is really possible to build what he calls a quest narrative, a journey narrative, a story in which I am not defined by my illness. I go from I am my cancer to I have a cancer to I am a person coping with an illness with folk around me. And again, that's not a straight line narrative, but a narrative with a purpose. So that framework helps me and helps our team think about how do we walk with who we call our companions on this quest, supporting their rediscovery of agency and purpose. Let me turn a little bit to Murty's work, the former Surgeon General, and what he calls the evolution of loneliness. Because there's a whole lot that's been written on the topic, and some things that are written more recently. Murty's book is, I think, almost a decade old now. But you know what? He wrote this book, and then not longer after we had COVID, which gave us a crash course in the lessons of what happens when connection is missing. We become isolated. That complicates our loneliness. Loneliness intersects with mental health crises or substance abuse disorder. All of those problems and more are interwoven with and complicated by economic and food insecurity or precarious housing. Pull at any thread of the spider web, it all shakes. Dr. Murty's work picks up on and amplifies earlier research, making clear that loneliness, like all emotional states, is rooted in our biology. How so? Well, loneliness works as a trigger, like hunger or thirst, to warn us when we are in danger of being isolated or alone. Why is that important? Well, we as a species didn't get where we are by our good looks or even by our physical prowess. We survive and we thrive really by our capacity to work together. And when that capacity is threatened, something deep in us is threatened. But here's what happens when loneliness or isolation goes past being a trigger and becomes a habit or pattern. We're feeling a little lonely, we reach out, that doesn't go so very well. We feel some sort of shame about that. We pull back even further, and it becomes a self-reinforcing cycle or pattern. and become kind of a hyper-vigilant sort of notion. When that does happen, this is a really busy slide, but the headline is this, that prolonged isolation is equivalent to smoking 15 cigarettes a day. So staying lonely, staying isolated has a significant health impact. So let me turn then from saying, that's how we got here. We decided to focus on this social impediment to health because it's what chaplains do well, and try to talk a little bit about our model and how it works. I think the model is pretty simple. Folks show up at any one of our hundreds of doors here at IU Health, and they're pretty motivated to share what's going on with them. The medical team refers a patient to a chaplain who is got the following criteria: 50 years of age or older, in a neighborhood with a high health inequity, and who may be isolated or lonely. The chaplain connects with the patient, builds rapport, relationship, and makes an assessment of whether referral to CCN might be helpful. If the patient agrees that that's a good idea, then a referral is made via our CCN social worker to a congregation in that patient's zip code. There is within each congregation a lead volunteer connector who matches that patient, their neighbor, with one of his or her team of volunteer connectors. There's 5 or 6 congregational connectors to each congregation. And then that connector and companion, the patient, agree to spend about an hour a week with each other for 12 weeks, usually over the telephone, but it can be in person in a public place or even at the person's home if that's what folk want to do. And the ultimate goal of this pretty simple model is that relationship, to provide a listening ear, to provide companionship. But a secondary benefit is if I spend an hour listening to you, I am going to learn all kinds of things if we build a real relationship. And maybe I'll learn that there is food insecurity. Maybe I'll learn that there is substance abuse disorder. Maybe I'll learn that there is a problem with transportation or some other social impediment to health. So our volunteers are trained about how to help people connect to resources either in the hospital or in their community. Maybe there's a food pantry at the church. Maybe there's a therapist they can call through the hospital network to help them get to the right door at the right time, the right door of a therapist or some other helper at the right time, hopefully earlier in their treatment or illness process rather than later, and not alone, accompanied by a member of their team. So here's another just picture of how this can work. Let me say this, when we began this work 5 years ago, I really thought most of our referrals would come from inpatient world. We have a wonderful CPE education fellowship program here, and a really brave CPE resident going into her second year, her year of fellowship, Reverend Dr. Natasha Howard, said, I'll take this on. It was our very first year, and she became kind of a pathfinder for us. So Reverend Howard partnered with the Dunlap Family Practice Center and another wonderful physician, Dr. Deanna Willis, Dee Willis. I just made you a Reverend, Dee, if you're on the call. Dee is like this great researcher, but she's also this great champion of her patients. And she and Chaplain Howard became fast friends. And in that first year, more than half of our referrals came from that relationship. So that became something of a model for us. And we learned that actually in an acute care setting like ours here, that patients at discharge may or may not be ready to talk about this kind of a referral. And so we now have 9 chaplains in outpatient settings and about 18 clinics across our 15, 16 hospital system And those clinics are identified as having a pretty large population of folks with high health inequity needs. And then the chaplain comes in there, and I don't, many of you out there in Transforming Chaplaincy world may have had a robust outpatient program. We didn't so much. And so our physician said, you know, we like you people, but what are you going to do? There's no room for you here in the clinic anyway. But what we did was slowly build relationships with providers, and the chaplains work to meet the needs of whatever patient might be referred to them. So that might be an adjustment to illness kind of thing with religious coping. It might be advanced care planning. It might be bereavement care. But often enough, it is that isolated or lonely patient who then becomes a good referral to our Congregational Care Network. So in this way, the chaplain serves as an extender for the physician or provider, and that congregational volunteer, the connector, serves as an extender to the chaplain. But here's the happy result for the health system, really, is that the communication pathway works both ways. Now, that clergy person has somebody they actually know that they can call when they have a problem in their congregation and need to get someone seen or have some connection with the health system in that way, which is really a happy result for all of us. Oh, let me come back to the slide a little bit, and I have to come back to it because there's one important function not on the slide, and that's our licensed clinical social worker. We don't have many social workers on our team, 2 currently, and bringing on a 3rd, and they provide a really important function. 3, in fact. So 1, they help with placement of a patient or a companion with a congregation. Secondly, and more importantly, they help if, as happens sometimes, a patient begins to demonstrate some behavioral or mental health needs that are beyond the scope of their care, and they can reach back out to the social worker who will provide guidance at that time, or perhaps even just take over the cares as needed in that moment. And then they're also helpful in guiding people to those community resources that are of need. We really try to, we do work hard with our connectors to help them understand their job is not to provide the needs for their patients, but to help them get to the right door. We actually have them say with us in the training, I'm sorry, I can't do that for you. It's fun to have about 20 people on a Zoom call saying, I'm sorry, I can't do that for you. But what I can do for you is walk with you to this door or that door to help you get to the right place. So again, the social workers are a critical part of that team. We support the congregations in several important ways. First, we provide a stipend of $1,000 a month to support their ministry. And second, with training and guidance. And I want to speak a little bit about both those things. The stipend of $1,000 a month is important because ministry is not a cost-free activity. We don't put really parameters around how they use that stipend. This is a flat partnership with congregation where they are really helping to teach us how to provide spiritual care to their neighbors. But that investment of the $1,000 per month is an investment in the health of that congregation. And we think that's important to our shared partnership, but it's also important to the community at large. So we feel like that's money really well invested. And then about training, we use a well-established curriculum developed by the partnership group, which is out of the Mental Health Chaplaincy in Seattle. They developed the companionship model to work with persons who are unhoused, who are living in the neighborhoods around them. And it is based on pretty simple listening skills and how to develop persons, care with persons in a way that is based on connection and mutuality. So over time, trust develops. And then as that trust develops individual to individual, then the goal is to help them connect beyond that individual to a broader community with over time, that individual having a community that works well to support them and where they can make contributions. That might possibly be the congregation represented by the volunteer, usually not. It's usually often a congregation or a family connection that patient used to have. What else to say before jumping on that? So I said what we provide to the congregations. What we ask the congregations to provide to us, and they sign a memorandum of understanding to speak to this, is that they provide us with 6 connectors a week. 6 connectors who will work with us, 6 volunteers, and those connectors agree to give 2 hours a week. 1 hour to providing care for their patient. That may be 1 long phone call or 3 or 4 short ones, but then 1 hour to spend in a small group with each other. And I think this is really important. I can teach you basic listening skills in 4 or 5 hours, but the doing of listening is really hard. I've been doing it my whole life, and like piano or like any other art, it takes continual practice and it takes consultation. So that small group is where they can share with each other and brainstorm with each other about how to best provide care that might come up in the lives of their companions. A chaplain or a clergy person from their faith group is a content expert in that group. Here's a simple diagram of how this works, and I'd amplify just one point here, which is maybe not clear from the slide, but we also connect congregations to congregations, and they provide support for each other's functions in the community, and that's a cool sort of byproduct. Let me turn attention briefly to opportunities, but also concerns. So there's a great opportunity in partner with congregations. Data shows that people who report spiritual connection with religious traditions have better health outcomes. And similar research shows that our patients have deeper trust in their houses of worship than they do with hospital systems. So there's great opportunity to connect a patient who's lonely with a companion, but there's also danger. And I think I heard it first in the Carolinas when someone said there's no hurt like church hurt. So what happens if a patient experiences her companion as betraying something sacred and valuable to them? What happens if an old church hurt wound is triggered and we in fact do more harm than good? There's also interesting research that calls for better, more refined methodology to look critically at what kinds of spiritual practices and religious traditions support good health outcomes and which may not be so helpful. Clearly, I believe our CCN models provide us with an opportunity to contribute to community health, and I'm also clear that we need to be smart and humble about the potential harms and be invested in continuous quality control. Real briefly, a colleague of mine back in North Carolina, Dr. Russell Jones, wrote a really wonderful book for other psychotherapists. He's a psychotherapist, obviously, who were afraid to talk about spirituality or felt unprepared to talk about spirituality with their colleagues. And in that book, Russell comes up with a fairly simple taxonomy about how to try to think through if a spirituality or religious practice is helping someone at a particular point in their life. Which you can read for yourself, but basically it's asking, does that person's spirituality help make sense of a complicated world, help increase agency, or does it in fact make someone more fearful, more hostile, or more isolated? And so in that way, pay attention to how spirituality can be harmful or helpful. The name of Russell's books, by the way, is Spirit in Session: Working with Your Client's Spirituality and Psychotherapy. So just close with this slide, this quote by Thomas Merton: what do we gain by sailing to the moon if we're not able to cross the abyss that separates us from ourselves? So the goal of all this is to support a spiritual journey, a journey that I think is built on an idea that's fundamental to all traditions, which is to love our neighbors as ourselves. And that part of that is involved in loving ourselves. So in fact, maybe part of the irony is the result of the spiritual journey is to learn to be really comfortable in your own skin and to be really comfortable with who you are. But that, I think, is best helped by being in healthy relationships with a healthy community. And that's our hope and goal. Since 2023, which was when this study ended, we've grown to about 40 diverse congregations and have trained about 460 volunteers. And that number is actually pretty big. We've had about 700 patients who've, a little bit more than that, have completed CCN. So let me turn this now over to my friend and colleague, Lexi Torkey, and I'll drive these slides for her. And I said I'd do a lot of dad jokes. I'll try not to drive into a ditch. There it is, Lexi.
Great. Well, thank you, Jay. We had the wonderful opportunity to partner with Jay. So I direct a center at IU Health called the Evans Center that conducts research and education on spirituality, religion, and spiritual care. And so we partnered with Jay to provide a program evaluation of the early part of the Congregational Care Network. And I'm going to present the results, a little bit about the methodology and the results of that program evaluation. And we also published a paper earlier this year in Journal of the American Geriatric Society about this. So we evaluated the first 335 patients from 28 congregations in Indianapolis, Indiana, and Bloomington, Indiana. And this was from the beginning of the program on August 20th, 2020 to February of 2023. So click enter. So it was a pre-post study that we conducted where we basically measured certain things that I'll show you about before and after Congregational Care Network participants. And our hypotheses were first that loneliness will decrease after the CCN program compared to before. So again, getting at that primary goal that Jay and his team set out with. And we also thought that this could affect healthcare utilization, and specifically that inpatient and emergency room visits, which are highly burdensome, would decrease during and after CCN program compared to before, and that outpatient visits will increase during and after the CCN program compared to before. Next slide. So we decided to measure, we did a little search of the literature to find an instrument and chose the DeJong-Gierval loneliness scale. And it measures two aspects of loneliness. First is emotional loneliness, which has 3 items. And one example is I miss having people around me. So kind of the emotional experience of loneliness. And then the experience of social loneliness, which is typified by the item, I can call on my friends whenever I need them. And these add up to a total score. So this was our loneliness measure. Next slide. And then we also measured healthcare utilization. We obtained this data through the electronic medical record, and an analyst at our health system helped us with that. It was then securely sent to our statistician, and he was able to code the data so we could identify visits to the health system that were sorted into 3 time periods: the 90 days before enrollment in CCN, the 90 days when CCN was being delivered, and then the 90 days after. And then we were able to identify several types of visits, and the ones I'm going to show you today are the outpatient or clinic visits, emergency department visits, and hospitalizations. Next slide. So this is another diagram from our paper that shows kind of the study timeline. And so if you look at the boxes across the top, those are kind of key time points. So the consent to CCN program either happened in the hospital or in the clinic. And that's when the patient agreed to participate and the pre-CCN loneliness scale was delivered. Then the program would take the name back and pass it on to a congregation, and that was the congregational placement. Of course, a little time would elapse before they had a first visit with one of the connectors in the congregation. And then after those, essentially 90-day time period was over, we did the post-CCN scale. So our 3 key time periods, we'll back up, were before program participation, during program participation, and afterwards. And you can see that enrollment interview we didn't analyze. It was either a hospital admission or a clinic visit, but we wanted to kind of leave that out because, of course, it would have massively inflated the cost of any, the visit number of any kind of period we dumped it into. So for example, if we counted everybody's visit as being part of the before, then we would have seen kind of a massive artificial decline in visit numbers. So we left that period out. Next slide. So here are our results. As you can see, there was a pretty broad age range, ranging, even though it was generally people over 50, we had a couple who were younger, but then went all the way up into the 90s. It was more women than men, which is fairly typical of programs like this. It was 59% Black or African American, a small number Hispanic or Latino, and we do have our population of Hispanic and Latino folks in Indiana is younger. And then they came, as Jay mentioned, from a variety, a few in the ER, but many from the inpatient areas, and then the majority from the outpatient area. And during the period, we had 7 people who died, and their data was removed again so that we wouldn't artificially inflate the early time periods. Next slide. So here's data on the emotional loneliness scale. And the scores for loneliness are located along the bottom. And lower scores are better. So as you can see, if you look at the before scores, there are quite a few more people who had scores of 1, 2, or 3. And then if you look at the after scores, you can see that more people had a loneliness score of 0, emotional loneliness score of 0, which means basically they're not reporting any loneliness at all. So if you click one more time, you can see that this was a highly significant difference at p less than 0.001. Then going to the next slide, the social loneliness scale had a very similar pattern, where you can see that basically if you look at the before and after, you can see that more folks had a loneliness score of 0 or no social loneliness after the intervention compared to before. And you can see that those scores generally shift to the left compared to the red bars. And then at the next slide, you can see that the total score has pretty much the same pattern. So this is a little bit, you can see if you look at the location of the bars that they're more evenly dispersed in the before period, and then they skew, move to the left basically in the after period. So really important differences on loneliness. Going on to healthcare utilization. This looks at inpatient and emergency department visits, so inpatient in red. And you can see here that compared to the before time point, first looking at emergency department visits, that they go down and they stay down. And those asterisks indicate that compared to before, the number of visits that the group had were lower during and after. You can see the same pattern for the inpatient visits, although those particular ones didn't reach statistical significance in this one analysis. And then if you go into outpatient visits, you see in a very different pattern where compared to before, during the intervention, the outpatient visits were much higher. And we regard that as a good thing, right? Because getting your care in a continuity setting as an outpatient is much better than having to go sit for hours in the emergency room or getting admitted. Interestingly, that increase in outpatient visits did not persist afterwards. And I think that's an interesting question about why. And I do wonder if it was really, the support of the connector, or perhaps connection with the social worker for barriers to getting to clinic, that just didn't persist once the program ended. Next slide. So every study has its limitations, and a pre-post design is a less rigorous design. But again, this is not a randomized trial here. This was a program evaluation. And we didn't have a control group. I can tell you, if I had more time, I'd tell our story about kind of trying to create a control group. And it, really was useful in some ways, but, JAGS didn't buy it. They said our control group was too different than our intervention group. And so a pre-post analysis was the way to go. Also, EMR data can be incomplete, and the congregation are not researchers, and they don't want to keep detailed information about, I visited with this person for 25 minutes on Tuesday, and so we don't have detailed information about visits. Next slide. So in conclusion, the Congregational Care Network was successfully carried out by 28 congregations and served 335 patients in 2.5 years. Next. We think several factors contributed to program success. One was, as Jay explained, referrals for the program were made by the patient's physician, social worker, or chaplain, and the warm handoff approach really built on existing trust. The congregations had to agree to serve patients of any faith or no faith, and connector training includes following standards common to chaplain practice in multi-faith settings with no proselytizing or conversion. And then communication flowed in both directions. Next. So CCN successfully addresses social isolation and loneliness, a major public health concern. And next. and improved healthcare utilization with more visits to outpatient settings for regular scheduled care and less burdensome acute care utilization. And if you look at the literature on improving healthcare utilization, it is really hard to do this. And so I really think it's a credit to Jay and the program that they were able to make this change with this program that was relatively efficient and relatively light touch. Back to you, Jay.
Thank you. So real quickly, I'll turn it over to Ellen. I chose this beautiful picture off the internet of a lattice or an arbor, because I like to think, we began mostly in the downtown Indy area, and now we've grown to Bloomington to the south of us, Muncie to the east and north, and Lafayette to the north and west. And I like to think of sort of the Congregational Care Network as a hopefully kind of a lattice over which some of these networks of care may grow over time. And I'm happy to announce the Centene Foundation came to us and said they were interested in would you put in a grant request? And so we got a really significant 2-year grant to expand into Fort Wayne and Allen County, where IU Health does have a presence. We're building a hospital, but also to expand into Gary in the Chicagoland area and Lake County, where we don't have a presence, and where we're going to be learning a lot of the excitement of this work is what we don't yet know. So we're going to be seeing how do we help this grow where we actually don't have a clinic where we'll be practicing. So more to come. I think I'll stop sharing my screen now and turn it over to you, Ellen. And thank you so very much.
Well, thank you very much. I hope you can hear me.
Yes.
Great. I am delighted to be here to see the transformation of transforming chaplaincy. I was a part of the advisory committee that worked with George Fitchett and Wendy Cadge on the original, I believe it was 2 years of fellowships that were given to working chaplains to advance their education in public health. And we were very pleased to have one of those. I know it was very competitive to get those fellowships, but we were very pleased to have one of those people at Pat Palmer here at Emory, and I was her thesis advisor, so I worked with her closely. And so that was a long time ago. I don't even remember when it was before the pandemic. I can definitely say that. But I do remember doing a few lectures from my bedroom for the evening classes also. Just totally by coincidence, I was at a meeting this past week with Eric Yesfeld of the Templeton Foundation, and it came up. Also, Wendy Cadge was there as well. And so, and he said something about this was like the biggest grant we'd ever done. And it was obvious that they were so proud of what this organization did and the, really bright ideas that started bringing research capabilities to chaplains who had the on-the-ground experience. It was just a really wonderful program. And now it's transformed into transforming chaplaincy. One of those chaplains is Kelsey White. I don't know if she's on the call or not. Hey, Kelsey, if you are. We've been working together on a grant with people at Albert Einstein College of Medicine on religion in palliative and end-of-life care. And so it's been a joy to keep working with this in different ways. Also, I lived in Bloomington for 3 years because my husband taught at IU, so I also know a little bit about Bloomington. Well, since I'm getting this little opportunity here, and since the Memphis model was definitely an inspiration for your program, I have a chance to plug Gary Gunderson's new book, which he just sent me a few days ago, Taking Responsibility for the Life of Complex Human Ecosystems. Subtitle is Deep Accountability, and that they just refer to it. This is Gary and Jim Cochran, his frequent co-author. And since you said one of your slides was just like, I said, oh, I bet Gary wrote that in the thing. I'm just going to read you 2 sentences. We need and can find, this is what the book is about, what we call deep accountability, taking responsibility for what we are capable of as human beings within whatever sphere of society or set of relationships we find ourselves. This is the opposite of grim duty. It is where we find our joy as we are meant to live. That's not exactly the way Frederick Buechner put it, but it is really very much about a match between what we have to offer and what is needed in the world. So sure, you should all get on Amazon and buy Gary's new book. So I had a few questions that I had jotted down just from looking at the slides ahead of time, and some of them were somewhat answered. One of the questions I had, since I am a sociologist and I do think about the relationships of individuals in society, but also the relationships of the institutions that they are a part of. And I think you briefly said something about the connection of the congregations with each other. I'd love to hear some more about that, because it fits really well with the concept of, social networks of institutions. And Gary and Jim talk about mesh works, or the sort of knitted quality that we have when we have, and that brings us more vital society. So have you had some conferences with the congregations with each other?
So two ways that we do that. We have a wonderful education department here that helps us with all of these things, and they lead us in what we call a monthly spiritual care grand rounds, which is aimed, and it's a Zoom meeting, but it's aimed, the primary audience are those volunteers. Secondly, we divide into regions, pretty small regions, and we call them pods for no particular good reason. And through those small pod meetings, the lead volunteer from each church, with about 6 or 7 per pod, meets with a chaplain once a month to share ideas, thoughts, and in that capacity can share things like, hey, we're having a luncheon this week. We're having a fundraiser that week. So they share both programmatic issues, and sometimes I hope we'll also be sharing some of the concerns that they are facing as a group. And that's trying to get up with our clergy and lay leaders and staying connected with them is not easy. And so this has become a good way to try to do that.
No, feedback loops are great. Could you also comment on how multi-faith your congregations are?
Yeah, less than I'd like. We have 3 masjids or mosques in the group. We are in conversation with a synagogue in town, but that hasn't materialized yet. And then we have a number of Catholic and a lot of the whole gamut of Protestant Christian churches. But there's a great opportunity to keep growing in that way. We do have some more cultural diversity than we do multi-faith diversity. There's a really significant Burmese and Myanmar population here in Indiana. We have connected with 3 or 4 congregations and that way. 1 Haitian Creole and several Latinx congregations.
Great. How many minutes do we have left? I had like 2 things. I'm trying to decide which one.
Yeah, Ellen, keep going. Keep going, Ellen, please.
Okay. Well, so there's a group here at Emory that studies social isolation and aging. They have some papers called Aging Solo. And I was at a presentation of one of the researchers, and they were giving some case studies. And one of them really perked my ears up because it was about an isolated older individual and a church congregation. And I, I wasn't expecting them to talk about that, but the story was that this was an older person with some pretty severe disabilities who had no connection to this congregation at all, but somehow became connected with them and was making, I would say, from the telling by the researcher, too many demands, like was expecting much more from this congregation than they were unwilling to or understanding why they should be giving as they And so I think there was a word, the word mutuality occurred in your slide.
Yes.
And I was thinking about how in social support research and sociology, reciprocity is a really important aspect of social support. And even when it's social support connected with religious congregations, the giving of support is just as beneficial for individuals as the receiving of support is. So, yeah. So I just wondered if that does the sort of apparently short-term nature of the relationships that you have here sort of prevent that kind of, I don't know, over dependency that some individuals might create.
No.
Yeah.
So we do have at the end of the program, we don't sort of kick folk off. We stopped keeping data, but if folk want to continue with their connector, then that that's up to the congregation, the connector, and the congregation, and that individual. We encourage folk to sort of wean off. And so I think there are stories sometimes of maybe that over dependence, over functioning than we'd like. There are also happy stories where folks become like friends. And there's a wonderful story that got picked up by our local NPR station of the companion and the connector go to dance class like every week and do a line dance together. I was trying to think of the term. So the whole gamut.
Well, that sounds like reciprocity to me. So
yes,
sounds
the other part, the over-functioning part also happens, I think, as well. And so we keep trying to stay connected with folk and encourage them along the way.
Can I do one more thing? One more topic? Okay,
Please.
so just this past Sunday in my church, they celebrated their 20th anniversary of the Stephen Ministries.
Yes.
So I just was dying to know, do you have Stephen Ministries in Indianapolis, and what connection do they have? Because it just seems like such a strong alignment of what Stephen Ministers do and what you're doing. And I understand this is their 50th anniversary nationwide, and it's non-denominational. I'm sure most people on the call know what I'm talking about.
Great question. And the Stevens Ministry is maybe the best known of that sort of peer-to-peer lay counseling approach. Christy Kozad-Norger, who's a favorite sort of theologian of mine, has written about a lot about this kind of work as well. But basically, we found that many congregations have some training, Stephen's ministry being the gold standard, and then often that will become the cohort of folk that join in with us. We thought about doing Stephen's ministry but went with companionship for a whole host of reasons. But we work with what the congregation brings to the table.
It's a natural match.
Yep. Absolutely.
We're down to about a minute or so. I've so enjoyed this conversation and of course, I love the research behind it as well. So thanks for all this. Jay or Eleanor, Alexi, I don't know if there's a question in the Q&A that looks like of more, you could pick it out. And while you're looking at that, Jay, could I share your work email address in the chat? There's some questions that came up, I think, specific to some really important programmatic aspects of what you described.
I'd be glad for you to do that. I'll put it in the chat. And
you'll put it in the chat. Okay.
I'm glad for folks to reach out to me. There are 10 other Jay Fosters running around IU Health. So this is Jay Foster 11.
This is good. Yeah, I'm just glad you keep running.
Glad to do that. And let me just say that I've got an enormous, if I can't take 1 minute personal privilege, just an enormous, wonderful team that actually makes this work. So Reverend Dr. Linnell Beatty is our director for the program. I see Reverend Dr. Anastasia Holman, who's our director of education, and Tanya Willows Robinson, myriad others. Those are the ones I see on the screen. So we have an enormous team in the CCN team and in the spiritual care group that it's a great privilege to get to work with them. And and Paul has also spent all day with IU Health because you're doing another thing on charting with some of our teams. So Paul, you need a break.
Well, I appreciate that. Thanks so much, Jay. And thanks for those kind props words. Ellen or Lexi, any kind of final thoughts from you before we sign off?
Oh, it was just a real privilege to be here. And I just love it that this program didn't just last for 2 years, that it has just evolved and grown and become much more sophisticated and is all over. Yeah, I love the hearts. Absolutely. It was a joy to be here. Thank you for inviting me.
Thanks so much.
I would just say that many, many more expensive and more in-depth programs have failed to have an impact on some of the outcomes that the CCN achieved. So I just think it's wonderful. It's hitting at something, just the right thing. It's doing the right thing to improve the well-being of people in the community.
Thanks, Lexi.
Thank you again for your contributions today. Friends, thanks for joining us. We hope to see you for the next Transforming Chaplaincy webinar, short course, or just hope you get our newsletter. Thanks for your engagement to advance spiritual care through research. Be well, friends. Thank you.